everyone. I'd like to welcome you to our IH recap webinar. I don't know if you've all had a chance to attend the ASMBS weekend in Louisville, but it was such a great presentation, and the Communications Committee is really excited to offer the top presentations for you to view at home without attending the conference. So really excited for our great lineup of speakers today. We're going to have each presenter present about 15 or so minutes of their kind of a snippet of their presentation that they did in Louisville, so we can just really get a taste of what happens at the conferences and get great education. As a reminder, the annual conference is coming up in May, so if you like what you see, this is a great opportunity to get signed up. So again, I'm Sarah Muntel. I'm one of the chairs of the Communication Committee. Also, Erin Rossi is my co-chair, and I'm going to let her take it away and do some introductions.
Thanks, Sarah. We're in for a big treat for today. First up is Dr. Kasey Goodpaster. She received her doctorate in counseling psychology from Purdue University. She's currently the director of behavioral health services at the Cleveland Clinic Bariatric and Metabolic Institute and is an assistant professor at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. She is an ASMBS Integrated Health Fellow, past chair of the IH Clinical Issues Committee, and is currently serving as a member at large on the ASMBS-IH Leadership Council. So welcome, Dr. Goodpaster. We're excited to have you.
Thank you, and thank you so much for inviting me to recap the presentation. I wish you guys could have actually been at the weekend because the other presenters in this course did a really fantastic job giving some context about burnout, but I will focus on my piece, which was practical evidence-based tools to improve self-care and resilience. And then I am going to encourage you to do some self-care right after you watch our webinar today. I should note that interventions designed to address burnout could either focus on strengthening individual capabilities to navigate the challenges of our work or more organizational, systemic sorts of interventions. And really the most effective burnout interventions address both instilling that culture of well-being in the workplace while also enhancing our abilities to cope with our work demands. But those organizational, systemic kinds of interventions can be really complex and time-consuming and feel sort of out of reach, at least for us to implement in a timely manner. So I am going to focus on what we can control, which is how we let our work affect us. I want to preface this presentation by saying that often we hear, okay, the self-care stuff sounds good, but I don't have time for self-care. But I would argue that if you don't have, 20 minutes a day to do something good for yourself, then you probably need extra self-care, and would encourage you to consider the sharpen the saw analogy. Suppose you were to come upon someone in the woods working feverishly to saw down a tree. What are you doing, you ask? Can't you see, comes the impatient reply. I'm sawing down this tree. You look exhausted, you exclaim. How long have you been at it? Over 5 hours, he returns, and I'm beat. This is hard work. Well, why don't you take a break for a few minutes and sharpen the saw, you inquire. I'm sure it would go a lot faster. I don't have time to sharpen the saw, the man says emphatically. I'm too busy sawing. So I think a lot of us can resonate with that, but really the message to take away is that practicing self-care is responsible selfishness. It doesn't truly detract from the other responsibilities that you have, but really recharges your batteries so that you can be more efficient and effective in all the things that you do. In a classic study, researchers gave physicians a small bag of candy to induce positive affect before a diagnostic reasoning task. And they found that those physicians considered the correct disease category significantly sooner and showed less bias than physicians who were not in a state of positive affect. So that's just one powerful example of how emotional state can influence our cognitive efficiency, even in highly analytical tasks, and really help us to work better. And some of what I'll talk about today is rooted in positive psychology concepts that were popularized by researcher Shawn Achor, who's the author of The Happiness Advantage and made popular, especially after this TED Talk that he did several years ago. And what he found from studying the happiest people is that happiness fuels success, not the other way around. Happiness leads to higher intelligence, creativity, and adaptability. And it also releases dopamine and serotonin, which in turn improve learning and decision-making circuits. In turn, positive affect leads to greater success in medicine and related fields. And the really good news is that retraining your brain doesn't take as long as you think. ACORS studies showed that doing some simple happiness boosting activities for just 2 minutes over the course of 21 days allows the brain to work more optimistically and successfully. So let's get into some of those research-based happiness boosters. Well, it turns out the happiest people aren't the ones that have the most positive things happening to them, but they're the ones that notice the positive things more so. So gratitude or counting blessings helps your brain begin to unconsciously scan the world for the good things that are happening, knowing that it would need to record it later. And there's multiple ways that you could do that, from writing down 3 good things that you're grateful for each day, or briefly journaling about one positive event at work twice a week. In a systematic review, gratitude was found to be associated with higher positive emotions, reduced negative emotions, reduced tension, reduced heart rate variability, and greater ability to find positive qualities in others. There was also an RCT done specifically in healthcare workers where they compared those in the gratitude diary intervention to those who had no intervention and those who were in a hassle diaries intervention. And they found that those in the gratitude diary group had a significant decline in stress and depressive symptoms after just 1 month of journaling twice per week. And those benefits were maintained for 3 months after the intervention as well. So again, it doesn't take a lot of time to see meaningful change. In addition to reflecting on the good things that have already happened, forward thinking is another research-based happiness booster. Positive anticipation of future events increases positive affect and activates reward circuits in the brain. It improves mood, buffers stress, and supports positive cognitive flexibility. Also, positive perspection of future work circumstances correlates with better affective states and may support performance. For example, specifically in healthcare, fostering meaningful upcoming events like team milestone celebrations, patient outcome reviews, educational retreats, maybe the ASMBS annual convention, prime better diagnostic reasoning, communication, and engagement. And so how to do it? It's as simple as just putting something on the calendar, even if that thing is pretty far away. It could be simple things like a night out or bigger things to look forward to like vacations. And so then when you need a mood boost, you start to reflect upon that positive event that's coming up and get to planning, because we do get more prolonged happiness from the planning process than we do from the event itself. Moving into acts of kindness, giving to friends and strangers has been shown to decrease stress and enhance mental health, and those benefits last for days. Small things like complimenting somebody or paying for somebody's coffee behind you count. One study looked at the effects of code lavender kits that were given to hospital workers to provide to their peers on stressful days. Those kits included a handwritten message, lavender essential oil, and a small piece of chocolate. And those simple low-cost kits enhanced feelings of peer-to-peer support among nurses, and 100% found them to be helpful. But of note, acts of kindness don't work as well retroactively, like thinking about something nice that you did previously. Really, these acts should be deliberate and conscious. Now, as I'm sure our viewers are aware, exercise is another key intervention for reducing burnout. In addition to the many health benefits, it promotes healthy detachment from work, enhances self-efficacy, increases energy, and improves mental health by acting as a natural antidepressant. And we tell our patients any exercise is better than none, and that's true for us in healthcare as well. A recent systematic review found significant mental health benefits can be achieved even below public health recommendations of 150 minutes per week. In fact, just 1 day per week is associated with a positive effect, though higher frequency exercise seems to yield the best effects in terms of reducing burnout. So while more is better, that means that as healthcare workers who likely are facing fatigue and time constraints can still reap benefits of brief bouts of physical activity, which is often more realistically attainable. So if you're not currently somebody who's making time for exercise, think about the advice that you would give your patients about one small step you can take, like wearing a physical activity tracker and then meeting yourself where you're at and building up from there. In this recent systematic review of the effects of meditation practices by surgeons, there were significant improvements seen in emotional, biological, and motor domains pre and post mindfulness and meditation interventions. Specifically, after those interventions, surgeons had lower perceived stress, burnout, fatigue, anger, depression, and a marked decrease in anxiety. They also had improved executive and cognitive functioning, including improved working memory. They had increased resilience and grit. And these benefits could be seen biologically as well, as there was a significant reduction in stress-stimulated signaling pathways. And these benefits not only helped the surgeons personally, but potentially helped their patients as well by way of improving the surgeon's surgical performance. Significant improvements were seen in motor functioning, including peg transfers and circle cutting. These results are consistent with results in other fields, which show improved accuracy, ability to multitask, and stress management when meditation is practiced for just 8 weeks. And once again, meditation practice doesn't have to be time-consuming. Even just taking 2 quiet minutes each morning, watching your breath go in and out, gently refocusing your thoughts as they drift, that's been shown to be one of the most powerful interventions to boost happiness. But you are likely to get more benefit if you make it a part of your routine on a daily basis. And that helps to keep the baseline stress low, also makes it more likely that you're going to use the tools in your times of need. There's loads of resources out there on YouTube, also apps like Headspace, which is my favorite, the Calm app as well. And if you wanted to try some of the Headspace content without paying for the app, on Netflix, there's 2 really great specials by Headspace, like a guide to meditation and a guide to sleep. As healthcare workers, we tend to not have much control over our environment. My office at work is basically closet-sized and has no windows, but we do try to make some small adjustments where we can to infuse some positivity into the surroundings as well. So if, like me, your office has no windows, try to gravitate towards areas of the hospital where you can get a little natural light, and ideally step outside for some fresh air when you can. Spending 20 minutes outside in good weather boosts mood and even improves thinking and memory. Also, every time that you look at a picture of a loved one in your office, that does give you a mood boost, so you want to keep some pictures around. And calming and meditative music can also add some serenity to your day if you're playing that in your office or even in the OR. Now, what I've been talking about so far are sort of micro interventions that can be done in a short period of time, but that's not to downplay the fact that some of us have mental health concerns and really could benefit from professional mental health treatment. And there is absolutely nothing wrong with that, no shame in that at all. But again, even as we encourage our patients to seek mental health treatment, sometimes it can be hard to take our own advice about that. So I'm going to give you a little pep talk about some common barriers. Sometimes we hear, well, stress is just part of the job. I should be able to handle it. But first of all, don't should yourself. Second, help seeking is a sign of strength, not weakness. And as we've talked about, self-care improves patient safety, so you could consider it to be your ethical duty to seek some help for yourself. You might also think that other people are going to judge you, but these days there's just so much less stigma about mental health treatment, and it's very common to hear people just casually talking about the advice that their therapists have given them. But if you're really concerned, therapy is confidential, and if it helps you feel better, you can always seek treatment outside of your health system for that extra layer of privacy. You might also think that your problems aren't bad enough for therapy. And I know I'm biased, but I really think anybody could benefit from therapy, whether or not you have some major mental health concern. In fact, it's better to seek therapy as more of a preventative measure rather than wait until it reaches a crisis level, because at that point it can be really hard to have the wherewithal and time to establish care. You might also think that you don't know where to look, but a good starting point would be your employee assistance program. They likely offer confidential short-term therapy and also offer a list of referrals for you. Another option would be going to your insurance company's website, typing in therapist, type your zip code, and you'll see who's covered in your network. And do know too that finding a good fit in a therapist is sort of like dating. You're probably going to know in 1 or 2 sessions whether that therapist is a good fit for you. And that fit is really, really important for the effectiveness of therapy. So don't give up until you find that click. And lastly, you might think that you don't have the time, but we did already talk about that. If you feel like you don't have time for therapy, you probably need it extra badly, and you really need to sharpen that saw. So just remember that therapy is going to help you to cope with your many demands, find strategies to improve your time management, and likely be a productivity enhancer both at work and home. And also, you don't necessarily even have to be going every week. Even just therapy once a month can be beneficial. So one final thing, if you're like me, you love the satisfaction of checking something off a list. So it's going to be more likely that self-care gets done if you actually have it on a list. At the beginning of 2025, I made myself a bingo board. This is not it, but it was a bingo board that just included all the things that I just kind of wanted to do this year anyways. Things like trying 5 new cheeses, going to 3 new museums, getting a facial, things like that. So I'll pay myself for each square that I complete and then extra for each row that's completed with the goal of at the end of the year to use those earnings for something like really frivolous as a reward for taking care of myself. But it's been a really fun way to incorporate self-care, and I would encourage you guys to do something similar. So right after this webinar, before you forget, just give yourself 2 minutes to either try one of the things that we talked about today that are on this bingo board, such as emailing a coworker something positive or downloading a meditation app, or just creating some bingo squares of your own that you want to work on kind of incorporating in this in 2026. And hopefully you can also use this to help make self-care more fun and motivating. Okay, thank you so much.
Thanks so much, Dr. Goodpaster. That was awesome. It's definitely a topic that we all need a little reminder of, and I'm gonna make my bingo card later today. We will do questions at the end of all this, so hold tight for questions at the end, but without further ado, we'll keep it moving. Sarah?
All right. Thanks again, Dr. Goodpaster. I was taking notes during that whole session, so I really appreciate your time today. I'm really excited to introduce our next speaker, Amy Laktash, and this was kind of one of my favorite sessions of the weekend. So I'm really excited that she's agreed to present her topic today, health disparities to consider in your practice. So let me tell you a little bit about Amy if you don't know her. Amy is a board-certified nurse practitioner with dual expertise in obesity medicine and bariatric surgery. She's a clinical leader at Flight Health, where she's helped design and implement a comprehensive obesity care program. She's an ASMBS fellow, the Integrated Health Chair, and the IH Star of Ohio and Kentucky. She's an active member in multiple committees, and she's previously practiced within the Cleveland Clinic Bariatric Surgery program, where she has served as a clinical coordinator. So thanks again for your time, Amy, and I'm excited to hear your presentation.
Yeah, thank you so much, Sarah and Erin. Let's go ahead and get started. Let's see. Okay, yeah, thank you. So today I'll be talking about health disparities to consider in your practice. And a lot of it is, obesity care has really accelerated faster than the systems that can deliver it. And the session really talked about, reliability by design and recognizing, who has access to care and who lags behind and how we can close those gaps. So here's my disclosures. But I'd like to kind of talk about, a paradox that we all face and experience in clinic. And, that's really as evidence grows, it still seems like access, shrinks. And we've had some progress in the past decade where some recent data has shown about a 1% increase in utilization, but we still know that less than 1% of eligible adults receive bariatric surgery. GLP-1 utilization is still highest among privately insured and higher income patients. However, utilization is lowest among publicly insured. Preoperative requirements and PBM restrictions can really create these, invisible access or gates to care. And we know obesity disproportionately affects, minorities, rural areas, and those socially most vulnerable. So as a result, this creates a problem where disparities are systemic. And when we have a utilization gap, we really see a prevalence where your prevalence rate does not mirror your utilization rate. And utilization really is our most clearest mirror of our utilization. In a high reliability system, again, utilization mirrors prevalence. So part of the solution is really creating these reliable, scalable designs for obesity care. So let's take a look at what happens. So let's think about our preoperative requirements. So nutrition visits, psychology evaluation, multiple months of visits. Much of them are built in for safety metrics or a part of our MBS Equip accreditation standards. But because of this, patients with more time, resources, or access get to these standards sooner, and those that don't have these resources will fall away. And because of that, because of these resources, those people can seem more motivated, where this motivation can then translate into more resources. And again, people without these resources can drop off during evaluation. When we look at GLP-1 medications, pharmacy benefit managers function as the same way. They really decide who get access to care, not based on evidence, but more off of rebate structures and formularies. And because of a multi-step, prior authorization process or formulary barriers, again, these create access and gaps to care. When you have better coverage, that can also mean you have better insurance or you're more connected. People can drop off at refills and side effects and misinformation. And although sometimes different, there can be different struggles with bariatric surgery and medications. We can have different systems, but really have the same outcome. And complexity really filters out those most socially vulnerable. And when we look at studies, we know different racial groups will be less likely to go through bariatric surgeries. And we know more and more insurance companies are struggling with the costs with medications, with some individuals or patients seeking to come off medications or can no longer afford it. So the other question that, I really presented during the discussion was we often face a lot of our attention on insurance and changing coverage, which is important. But you really, if every barrier disappeared tomorrow, could we meet demand? And, the World Health Organization released a really compelling paper recently, and much of their focus also was really developing systems that can meet the demand because we're really not there yet. And a lot of it is because of some of our system designs. And what I wanted to focus on was really looking at this hidden architecture of disparity and how systems can sort patients. And when we look at our multi-step pathways, they can really create these socioeconomic filters. Implicit bias can be sneaky. It can hide in our workflows, scheduling, authorizations, and prescribing patterns. We can create this subtle gatekeeping based off transportation, time off work, childcare. Those, again, who have these resources can seem more ready. So as a result, social determinants of health can really act as these de facto eligibility filters. We know one of the most important factors is safe and affordable housing. It really provides access to, sanitation, to stability, safety, and access. Poor housing leads to overcrowding and inadequate sanitation and environmental hazards. It can create chronic stress, and those can also have more chronic health patterns or probably chronic health problems as a result when they look at the data. So when we break this down, affordable housing, those without it can move more frequently and find themselves in food deserts. Food insecurity can result in, failing preoperative requirements or developing malnutrition after surgery. When you live in a rural location, you can experience a travel burden or limited access. In job inflexibility, if we think about people who might have hourly work requirements and the demands of all the preoperative report appointments or follow-up. And we know that, wealth or financial stability can really act as a buffer for hardships, and they can handle some of these emergencies and stressors easier, where these systems can then really create this funnel on who gets to surgery when we look at the multiple step requirements, passive referrals, and again, our social determinants of health. And this is what creates this utilization gap that we can see. So also what happens with equity work is when we, really confuse activity with impact. And where we focus our effort is really how we can change outcomes. And a lot of it's kind of is structuring kind of low effort, high impact changes. And that's really where we want to focus our effort on more. When we collect a lot of this data. If you have a system like a large EMR like Epic, we're collecting, your social determinants of health on every intake, but unless it triggers a resource or a workflow change or referral, again, it's really activity and it's not really changing impact. So looking at, what does this look like in practice? Adding in 2 to 3 social determinants of health questions into a preoperative intake or to your workflow, continuing with telehealth visits. Some of the conversations I've heard is that there's been, somewhat of a change moving away from telehealth. And I think really with obesity medicine, that is such an important framework for access. Offering evening or weekend clinics, shared medical appointments, or really developing a community health champion that's really an expert on the resources in your area. Tracking no-shows by insurance type or looking at referral patterns, not just by your colleagues or service lines, but also by insurance, zip code, and demographics. So these are quick wins that immediately identify unseen barriers and reconnect you with patients that you're already missing. And then we move to high effort, high impact changes. And those are things that we're doing with advocating for coverage parity, redesigning our preoperative pathways to reduce friction, opt-out enrollment programs. And that's really triggering a referral to the patient where they decide whether to establish with a program or to fulfill the referral and not relying on a referral from a primary care or another service line. Creating navigation rules for outreach. And these are system redesign that addresses long-term utilization and really equity at scale. And where we want to keep our focus away from are these effort, low impact changes. And this is where we can start to confuse our activity with impact. And that's updating our handouts or holding one-off awareness events or social media posts. They're cosmetic changes and they can seem like they're having a lot of impact, but they're visible. They rarely change access or outcomes. And then our high effort or low impact changes. And that's overhauling our EMRs without really any equity data or strategy, adding extra approval steps to our process. This will consume resources, but it really doesn't solve the utilization gap. And a lot of it really comes down to, mapping your blind spots, really looking at who's not showing up more based on insurance, zip code, and demographics, and really picking one metric. This can get a little overwhelming. There's several social determinants of health, but picking one metric to follow and tracking those outcomes over several months. So where we look at, with my, let's take a look at, maybe on a granular level of, what happens when we do redesign strategically. And I'd like to present, our data in our practice with my colleagues where we partnered with a state health plan who reached out to us to partner with our clinical services because they really got to a point where they were going to have to remove GLP-1 coverage from their formulary for their participants because they simply could not afford it anymore because of the GLP-1 prescribing rates were really high. And we looked at our data over 12 months and we had 4,000 participants in the study and we looked at our prescription drug claims and our clinical data. And really what we wanted to analyze was our cost impact and medication adherence and treatment persistence. When we looked at things in the beginning, there were some things that stood out. And really, what was interesting is that those with the lowest BMI and acuity had the highest prescription drug cost. And really, what that says was that they had the highest GLP-1 utilization. We had high rates of obesogenic medication prescribing and really misdiagnosis from not really being a part of a comprehensive obesity medicine practice. We had our financial study independently verified by Milliman, and our clinical study was done by our program. And part of our cohort was that everyone that came in completed a health risk assessment and got an acuity-based score based off their weight-related health problems, and other social determinants of health. And we really assigned them medium, high, or an extreme acuity. And they were seen every 3 months by a physician or nurse practitioner and a dietitian with those visits staggered in between. So they essentially saw somebody every 6 weeks. They had access to a cellular scale and blood pressure cuff, and then our our app where they had lifestyle intervention. And we looked at our data over 12 months. And because of this design and this program design, we really were able to change the curve where the strongest utilization really shifted to the highest acuity patients, and that showed risk stratification impact. We actually transitioned 1 in 3 existing individuals, legacy patients, GLP-1 patients, to lower cost alternatives. But we really had strong outcomes. We had 17% total body weight loss in the GLP-1 group, 13% total body weight loss in a non-GLP-1 group, and we had an 86% GLP-1 adherence rate, where when we look at real-world data, GLP-1 adherence is around 15 to 17%. But through this redesign, we were able to develop or deliver almost a 4 million cost saving to a single payer in 1 year. So I think it really shows when we kind of take a step back and have some thoughtful redesign with some low impact changes, we can really deliver scalable obesity care that's really high level. So where do we get started, and where would a program kind of find where their blind spots are or mapping their disparities? So you can access this data at the CDC, going to their, social determinants of health and looking at your areas by zip code. So I really kind of mapped our areas looking at, certain counties and obesity prevalence rates. So we looked at Lucas County having, the highest obesity, prevalence under minority areas, along with Montgomery County and Hamilton County. And where we would kind of look at if we're having a utilization gap is if our, surgery utilization or an obesity medicine practice, if our utilization kind of really mirrors what we're seeing kind of on a demographic level. So how a program would really kind of understand if they're having a utilization gap, if 40% of your local adults with a BMI over 35 are of a lower SES or a minority population, but your surgical population only reflects 10% of that population, really that's a utilization gap, and finding a way that you can change that curve would be an area to focus on. So part of also with obesity care is really we need to find ways to scale this reliably. And, how do we move this from a pilot to population? And that's really this concept of precision obesity care. And we really need to develop systems that are ready to deliver comprehensive evidence-based obesity treatment. And really developing this treat to target model. And when you treat to target, you're really acknowledging that different individuals will require more support, more time, more tools or resources to reach the same target. And we really didn't need to develop these cardiometabolic centers that can get one person to the same treatment target, even if they don't have coverage for bariatric surgery or for GLP-1 medications. And that's having an understanding of our first generation medications that are very effective. And really kind of looking at, if we talk about some of these barriers, could we really meet demand? And we really need to develop ways to deliver scalable obesity care. So I do feel our biggest hurdles that we're facing currently are moving away from talking about weight loss and talking about cardiometabolic health. And again, delivering cost-effective, scalable obesity care. And, really, again, combining surgery and medications. We have, several tools available, kind of moving away from this surgery versus medications, but really treating to target, identifying who's most effective for which treatment model. We know that, again, certain individuals might not respond to medications or surgery. And again, not being stuck on this conversation of surgery versus medications, but really developing comprehensive centers. So I really feel that the next leap in obesity medicine isn't more science. It's really developing a system that can reliably deliver the therapies that we already have. So really the call to action or kind of leadership in the next, 30 days, and what I left people with is mapping your own blind spots over the next month, looking at referral or refill data and finding one gap, looking at who's not showing up for visits, labs, or referrals, and really identifying patterns based on insurance type, zip code, or demographics, and implementing, one low effort, high yield change. picking one metric to track this month and, bringing one utilization finding to your next meeting and really looking at how, redefining success. I mean, we're really amazing at defining our outcomes, but looking at utilization alongside our surgical outcomes, keeping a log of observations and interventions. And at the end of the month, identify, one small quick win and one persistent barrier to inform the next steps. And, I listened to this talk by, Donna Ryan, and this quote really resonated with me. And she really left us with that it can seem that, more tears are shed over answered prayers than unanswered prayers. And we really have, more of the therapies that we really ever, thought of or prayed for. There's more and more science coming out of every day. And the real challenge is, creating systems that can deliver the tools that we have reliably and that everyone can access them. And utilization, again, is our mirror. It reflects who we're reaching and who's not having access to these services. And leadership is really kind of deciding what we want this next year to look like. We're coming up on 2026, and we can really decide on what this is going to look like. So, again, equity is not simply awareness, it's reliability. It's two different individuals having the same access to care in the same system. Reducing health disparities is really key to improving health outcomes and really looking at utilization as our mirror. It really can reflect where the care breaks down. And scalable obesity care does not require, heroics. It requires a system redesign and really taking it back to prescribing GLP-1s judiciously and equitably. We're seeing some more cost savings, but until they're more affordable, if we still continue to prescribe GLP-1s at high rates, then we're continuing to keep it out of the hands of people who need it the most. And leadership really means developing cardiometabolic systems that deliver consistent outcomes, both across surgery and pharmacotherapy, and identifying that treat to target model that we have the same target, but people may need different pathways. And lastly, I left this, call to action or consideration for really developing an MBSA equipped standard for an equity and a utilization improvement model. And I'm not sure if these slides will be available, but I had it available on the weekend for different resources or tools if programs are ready to put this into action for social determinants that we can utilize. Thank you.
Whoops. Thanks so much, Amy. That was great. I really enjoyed too what to do in the next 30 days. I thought that was great. So I'm taking a lot of notes and taking this back to my practice. So
Thank you.
thanks so much.
Yeah, thank you, Amy. That was great. Next, we have Maia Routly Mansfield. She has been the manager of the Strong for Life Clinic and Bariatric Program at the Children's Healthcare of Atlanta since 2022. Maia has been a nurse for 29 years in has specialized fields of pediatric trauma and now pediatric obesity. Maia obtained her master's degree in human relationships from Liberty University and her doctorate in nursing practice from Quinnipiac University. She is passionate about furthering the science around obesity and adding to both the research and evidence-based practice literature. She currently serves as the Integrative Health Star for the Georgia ASMBS, participating in the National ASMBS Access to Care Committee. Maia spends her free time playing in an alternative rock band and hanging out with her husband and their kids. Today, Maia is going to talk to us about enhancing the state chapter experience. So, Maia, feel free to take it away.
Thank you. And I'm going to try to share and hopefully you can see well. Thank you so much. This has been so fun listening to all of these presentations, and I am very grateful to be along with my colleagues sharing these things. I'm going to take some time to share a story with everybody. So it's going to be a little bit different. We're going to talk about advocacy and revitalizing a state chapter and just kind of going through what happened here in Georgia. I have no disclosures. And what I would like to do is through this story, share with you some of the foundational aspects of advocacy and then kind of help you think about how these might be leveraged in your own state chapters. So, little story about Georgia. In 2013, our bariatric surgery was removed from the Georgia State Health Benefits Plan. And it took multiple years for anybody to be able to tackle this problem. But in 2018, a group of 5 surgeons in the state met at a round table after the Georgia ACS meeting. And then that same group got together again at the national ASMBS meeting and started talking about what do we need to do in Georgia. And they came up with this idea to have a day that was dedicated to talking about obesity just in our state. And so they called it Obesity Day and they hooked it to the ACS annual meeting. They figured people are already traveling, they're already going to be together. So this was a great way to go ahead and get them interested for all of those surgeons who are doing ACS to start doing having time together for ASMBS. And then audaciously, they invited local politicians. So, Obesity Day 2019 happened, and they chose a beautiful area. Fortunately, here in Georgia, we have some really pretty venues, and they had the first day at the King and Prince Beach Resort in South Georgia. And during that time, they established a vision for the state chapter. They had some ideas of what they wanted to do, but one of the biggest things that they did before this day was they prepared. They assumed that these politicians were going to come because they invited them. So they spent time trying to really figure out what do we want these people to know and what do we want them to do for us. And so they had a very targeted approach of showing that we have an obesity problem in Georgia. And look, we have this huge group of people that don't have access. And then they brought up the map of we are only one of 6 states that has this problem and nobody wants to lag behind. So it started a conversation of what more do we need to bring Georgia up to speed to be in this conversation of having great access and giving great care. So there was a lot of networking that happened, and they determined a path forward of furthering the mission of the SMBS and obesity care in Georgia. So during that meeting, which happened in August in 2019, they decided to do an awareness day in Georgia. And if you look at the dates, I mean, the work that they accomplished in a very short period of time is pretty phenomenal. So the Obesity Care Awareness Day happened in February of 2020. By this time, they have established a state chapter president, a new VP. They started an Access to Care Star, and then they started involving integrated health as well. And so people started hearing about our Georgia state chapter and the membership started growing. One of the biggest things that they did to help that was to hook our state chapter membership to the national ASMBS membership renewal so that when you go in to renew your national membership, it asks you the question, do you want to renew your state chapter membership? And it's just easy. So a lot more people start to do it. Things that happened between the Obesity Day in 2019 and this Awareness Day in 2020 was a visit to the governor's office, visits to the lieutenant governor's office, lots and lots of social media, lots and lots of emails and phone calls. And as everybody remembers, as 2020 progressed, COVID kind of happened. And so this is where energy is a big deal in advocacy. If the energy fizzles, then you're not going to get the impacts that you are looking for. So despite COVID, despite all of the different things that were happening in the offices and hospitals, this group of people continued to write emails, make phone calls, have Zoom calls. And by 2021, metabolic and bariatric surgery was added back into our state health benefits plan. And if you look from 2019 to 2021 is a long time period, but all the things that had to happen to make it so that this would be put back into our state benefits plan, and nobody stopped working. They kept going the whole time. So it was really phenomenal, and we were incredibly proud of this achievement in our state. And the big things were it was a targeted approach when they met with the different leaders who had influence and who had power. They made it about the issues that were important to the leaders. So they did the homework beforehand. They found out what was important to the governor, what was important to the lieutenant governor. And when they wove in the things that we wanted into the things that were his priorities as well. So from there, we didn't just stop. We're like, we made something good happen, but we want to keep going. So Obesity Day has continued. In 2022, they had their inaugural integrated health panel session. So essentially, what the surgeons did is they got in contact with some of the integrated health people and said, we want you guys to run an entire session about things that all of us need to know. And so they actually put it after lunch because they thought the integrated health people would be exciting. And they felt like after lunch, we would help everybody wake up. So we did that. And then in 2023, they started the fellow video competition and allowed fellows around the state to come and present their videos. And they were able to have a podium presentation that they can add to their resume. And at the end, they get to say what they got is if they won or if they came in second or third. And that year, they voted to add an integrated health seat to the board to increase the voice of the integrated health professionals in the state, to round out in our state chapter what was happening in care. Obviously, the best care is multidisciplinary care. That's the type of program that we all work in. And they wanted to make sure that with the state chapter that we were making use of everybody who was available in our state and who was involved in obesity care. So in 2024, Obesity Day, we launched the Georgia Bariatric Learning Lab. And essentially, that is a coalition of, I think it ended up being 24 programs across the state, all sharing data, sharing SARS, and looking at quality in our state and sharing best practices. If we see somebody who's just really performing incredibly well, what are they doing that other practices can incorporate? So Obesity Day 2025, we actually outgrew the King and Prince Resort in South Georgia. So both the ACS and the ASMBS had to move to a new venue. So we actually moved to Amelia Island. And I have to put a plug in for having a wonderful venue for your meeting because it encourages people to come. We actually got some wonderful out-of-state keynote speakers for both our main sessions and our integrated health session. And by this time, we had the third year of the fellow video competition. And from what I understand, they had to turn away some videos because there was so much engagement of people wanting to share their work and be a part of this. And we started the inaugural integrated health poster competition. So we invited all of the integrated health professionals around the state to submit their projects and to submit their work. And the really cool thing about this was that the board bought into giving these people something to win. So what they did is if you submitted your poster and it was accepted, we actually had everybody vote on the quality of the posters. And the poster presenters got their feedback, and the winner of the poster competition actually got a free registration for the 2026 Georgia ASMBS meeting. And that was really helpful because a lot of times the maybe integrated health professionals, it's more difficult for them to get to these state chapter meetings, and it gave them more reason to try and go. We had phenomenal projects that were submitted for the competition, and it was really fun to see how many people were engaged. We had over 100 attendees at this meeting. And again, we had an out of space state speaker share in the integrated health session. And basically, the hook that we had for her was a beautiful venue and a lot of interested people there to be able to listen to her talk. So it wasn't just about the meeting, because yes, we can all get together once a year, but it has to do more with what are we doing all the time? Once you get inertia, how do we keep that going? So outside of the meeting, we continue to collaborate with the state in furthering obesity care. We had multiple members of our state chapter visit with their own representatives. We took advantage of the ASMBS national meeting and went and visited them all at the Capitol. And one of the really fun things is when we went to that in-person visit, two of the four people, at least that my group met, we'd already met them before in the Zoom meetings that we had done prior to this visit. So it was like going back and talking to a friend. We'd already had the conversation. They remembered us. We brought up the same topics and were able to use that as a springboard to continue the conversations on those topics. We continue to collaborate with integrated health members throughout the state. We have updates that we send out to them, and we have a survey that we do that is kind of like a pulse check of what is important to integrated health in our state. And last year, 2024, what they said is they really wanted more exercise resources. So we've spent the year in 2025 creating an exercise toolkit resource that we can put on our website that any program across the state can access and say, okay, here's some general overviews of exercise that have been put together by exercise physiologists, because not every program has one of those, and they can have some place to start. So our past president is now the chair of the National ASMBS Access to Care Committee. We also have shared our success. You see the article that was published in our Success and Advocacy, the Georgia Story. And then with the Georgia Bariatric Learning Lab, that has been a fantastic way to collaborate across the system and learn about what things are big deals in each of the different programs and then work together. So we've actually used the Learning Lab as a springboard to launch the Georgia Bariatrics Quality Collaborative with 10 participating systems around the state and learning on creating frameworks of quality to do quality projects, like planned quality projects that include all of those programs and do a state quality program or project through 2026. So when you think, okay, that was great that you guys did that, but how did you accomplish it? And really, what you need is you need a unashamed champion, somebody who's willing to go out there and spearhead some of these things, and then you need a team around that person. And really, it can be anybody. At the weekend, I challenge the people in that room of maybe this champion is you. Maybe you are the one who has the energy that can get this group of people who can really start the movement. The starting is always the hardest, but once you get the inertia going, it's much easier. And the thing is, you've got to have a vision. You've got to have a path. If you are trying to accomplish too many things or you're not really sure where you're going, you're not going to be effective. It's really helpful to choose one thing and then have a very concentrated vision and effort and energy on that one thing to keep things rolling. The other thing is that you really have to have relationships. You need to foster these relationships within your own chapter, within the national society. And then if you're talking about advocacy, it's with representatives, your state representatives, your national representatives, your governors. These are the people that can really legislate change. And Chris Gallagher is such a phenomenal resource with the ASMBS. When I had my first Zoom meeting with one of my representatives, I was so nervous, and it was incredibly helpful to have him there on the call with me because it's just calming because you know there's somebody there who knows what they're doing, they know what to expect, and you're not just there by yourself. The other thing is to establish relationships with your insurance companies, who all the different levels of that, and your system administrators. Get your hospital or your system or even your office administrators really dedicated to what you are trying to do to advance obesity care. Relationships help you get the word out. When you're sharing and raising awareness, the larger the audience, the more interest you will garner and the more you can accomplish. So where do we go from here? Obviously, we've made great strides. We've shared some successes. We've had some great successes, and we don't want to stop. So we want to increase collaboration within our society, and for us, we really want to get more integrated health members involved. So we're going to continue our survey. We actually sent out our 2025 survey last month and are very interested to see what is going to be the top priority for integrated health members in our state. And we'll create a project to address whatever comes out as the top issue. We're also going to continue the poster competition, and we're so excited about the different projects that people are doing throughout the state. And we hope they really are going to bring more of those projects to our meeting this year. We also want to increase engagement across the state with continuing the fellow video project. And we offer bariatric specific CME at the ASMBS Georgia State meeting as well as at the ACS meeting so that they can get, if they come to that week, get all of their 8 hours of bariatric CME just all in one spot. And we've encouraged the surgeons across the state to bring their integrated health staff to that meeting. I mean, really, if you're just going to do Obesity Day, it's one day and it's not that far away. So, pretty much, we feel like a lot of people across the state can get there. And we continue through the Georgia Bariatric Quality Collaborative to seek funding from outside sources so that we can, one, to launch more projects and do more quality programs, and then to share. I know that Dr. Heckman Bleckner has shared the Learning Lab at several different national meetings and trying to help people understand that you build this framework and you can increase collaboration, which increases relationships, which just furthers all the aims of your society. So we want to create best practices within our state and make all of our programs better. And that is all of I have. Thank you so much.
Thanks so much, Maia. That was awesome. I love all the really practical advice. I feel like that's so helpful with getting people started. And with that, I do want to open up the questions, but as you're going through it, thinking of me as someone who is an IH member, it's hard to get involved sometimes, and it can be really intimidating, especially in states that have bigger chapters and are more involved in things. So what do you think is the best way to increase the IH presence within these state chapters?
I think having partnerships is really important. I can tell you that most of what I shared for our state chapter, I was not involved in because I did not come into this field until 2022. And going to my first Obesity Day meeting, first of all, it was finding out that it was a thing. You know, you can't go to something if you don't know it exists. So, one, if you are somebody who's in integrated health in your state chapter, go to the website, find out what's happening, and then look at the names. If you have a board members or things, look at the integrated health person who might be listed there, or if they have an event, go to that event and see who's talking, and then contact that person and just introduce yourself. I've had people send me an email and be like, "Hey, I saw you speaking at blah 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 thing, and I would like to know how to get involved." And so we set up a call or we set up a meeting and we go through it and partnering with somebody because generally you'll have ideas that I don't have. And maybe I've done something that you're like, "Hey, I have this great idea." And I was like, well, yeah, I tried that, it didn't work. And maybe you have an idea of where the way to tweak it where it will work. So I really do think that just talking and starting conversations is the way to go. And partnering with a surgeon, if you have a surgeon who's like, I'm all into getting integrated health people, use that person as well.
I think
So,
that I think that's awesome. I definitely want to start a survey. We don't do that often, so that's a really great idea just to kind of see what members are looking for. So thanks for your tips. That's great. Good deal. I have a question. Again, enjoyed all of these presentations. Thank you guys so much. I think this is a perfect taste of the weekend, if we have all the different sessions. So thanks again. Amy, I really enjoyed your presentation. I do have a question. How do you think programs could really increase treatment utilization? So what are some kind of steps that we should take?
Yeah, thank you. I think first is really making sure that somebody in the practice can treat or provide obesity care despite having coverage for surgery or medication. So really knowing how to use every tool that we have, and that's an understanding of, surgery, GLP-1 medications, but also, our first generation medications that I think get lost in the conversation that are really highly effective. And then I think also, really looking at your community resources and kind of looking at your demographics on who you're accessing and who you're not. And really just picking again, going back to like that one metric and trying to make a change. I listened to a community talk for maternal health, and they picked 30 moms that they really try to get from the time that they find out they're pregnant till their pregnancy. And it can seem like really like 30 moms, like what, that's not many people, but you think about like just that downstream impact it can have. And I think really focusing there, and you can be surprised on like the snowball effect. So I think it's twofold. I think it's again, really all programs need to be able to deliver care despite anybody's coverage, utilizing generic medications plus surgery and GLP-1 medications, just not relying on one tool. And then also just kind of looking at your demographics on who you're reaching and who you're not.
Oops. Great practical tips. I think everyone's kind of looking at their practices now and, with changes and for the upcoming year. So I think this is very timely. So thanks for that.
Yeah, thank you, Amy. One last question. So for Dr. Goodpaster, you talk about all these different self-care options, and a lot of them are really great. But like you said, sometimes you're kind of stuck in the environment that is your work environment. So in looking at the home environment where maybe we do have a little bit more flexibility, I often like to look at things that maybe are a little under the radar. And one of those is sleep. Sleep impacts obviously everything throughout your day. And if you sleep poorly, it just ruins the next day. So, do you have recommendations maybe for improving that sleep, either like the quality, duration, but just sleep in general?
Oh, that's a really good point, Erin. Thank you for bringing that up. And you're right, sleep is so important for our self-care, our mental health, our physical health. And I think something really important to remember when you're trying to improve sleep is that our bodies really thrive on routine. So you want to go to bed within the same hour every night and have the same kind of relaxing routine that you're doing every night to help prepare the body to sleep. But that routine should not involve artificial light sources because our phones, TVs, not only do we get wrapped up in like all that doom scrolling that can make sleep difficult, but also artificial light stops our brain from releasing the melatonin and kind of tricks our brain into thinking it's time to be awake and tossing and turning and things like that. So other ideas would be reading, listening to audiobooks, taking a nice hot shower because that change in temperature from hot to colder, tends to prepare the body to sleep well, or deep breathing, meditation, exercises. I know earlier in my presentation, I mentioned about those relaxation apps. The Headspace app in particular is really good because they have sleep stories where it'll describe in a really, really soothing voice a peaceful scene like a beach, meadow, library, whatever. But it does help to give the brain something to kind of hang on to because our brains tend to just go into overdrive when we hit the pillow. So a peaceful scene, some visualization can help a lot. And there's some other strategies that are on that Headspace Netflix special that I mentioned as well. Thank you for asking.
Great tips for sure. Thanks for that.
All right, and with that, we are out of time for today. So I do want to thank all of our speakers for joining us today. Your presentations are really great. It's a great precursor to what we can kind of see going ahead to meetings, whether next year's ASMBS weekend. But sooner than that, we have the annual meeting in May in San Antonio. So these are great presentations to show you the quality of what we bring to these meetings as IH members. In looking ahead to that meeting, abstract deadline has been extended until January 4th. So feel free to submit any of your abstracts and look ahead for more communications committee webinars, networking events. We're always doing something. We're happy to have as much involvement as possible. So thanks, guys.
Thank you all so much. Have a great day.